I want to thank you all so much for your incredible support of Barrow's stroke program. And I want to thank you for taking the time out of your day to learn about the amazing research that's going on here at the Institute. You know, there is so much medical news happening today, all really dominated by the pandemic. We are in the race for the vaccine. We're looking for better treatments. We are trying to figure out how to get people back into workplaces, how to get kids back to school. We're working on care for the caregivers. So much is going on. But at the same time, there is so much groundbreaking research happening, particularly here at the Institute, that we wanted to take the time to share with you. And we're thrilled to begin the process today with the stroke program. And the stroke program is doing a lot of amazing things. In particular, some of it has implications for COVID. So we, again, are grateful to you to give us your time today and learn more about Barrow's stroke program. I am going to turn the mic over to Dr. Michael Waters. He is the Dorrance Chair of Vascular Neurology and our Stroke Program Director for the PetSNCC Stroke Center. And additionally, joining Dr. Waters will be Dr. David Wong. He's the co-director of the Neurovascular Division and Stroke Program, and Dr. Paul McDonald, a neurologist in the Stroke Program. But before we get started, one more time, I just want to say thank you again for your incredible support of the Barrow Neurological Institute. And now, Dr. Waters.
Thank you very much, Katie. It's a pleasure to be here, and I'd like to echo her sentiments in thanking you all for your support in the past and for your attendance at this event. I hope that you find it informative and worthwhile. Just wanted to let you know kind of what we're all about here in the Barrow Stroke Program. We have goals and we have objectives, and quite simply, our mission is to lead in the provision of high quality, comprehensive, state-of-the-art stroke care. And that's what we're set to do, and we want to put ourselves in a position where we're able to do that reliably and consistently. And that mission really underlies what our purpose is, and that's really to reduce the burden of cerebrovascular disease in our community. We buttress this goal with 5 pillars. One is community outreach, and we're very active in the community, educating people and our population. It's very important that they understand the signs and symptoms of a stroke and understand the correct process if they see anyone, friends or loved one, who may be suffering from a stroke. We also work very closely with the hospitals, our hospital system and others, as well as EMS and pre-hospital care providers. Continuing education is a focus for us, not only in the community, but amongst ourselves as well. We have to be up to date on all of the latest in order to provide that to our patient population. Clinical excellence is really a cornerstone of what we're all about here, and I think that we are provide that for our patient population, and will continue to do so in the future. And of course, research and innovation is fundamental to improving our care and expanding the possibilities for patients in the future. Now, it takes a team to do that, and I'm very privileged to work with these dedicated individuals who are extraordinarily well-trained and focused on providing outstanding stroke care. All of us, we're a group of 7 now, and that's quite a bit of growth in the short time that I've been here. In fact, I think it's probably one of the largest vascular neurology groups in the state of Arizona, to be quite honest. All of these individuals have specialty training in stroke and neurovascular disease. All of them are board certified in the subspecialty of stroke, and we are here in an effort to provide the clinical excellence that I spoke of earlier. In addition, we want to train the next generation. So every year we have 2 neurovascular fellows. They are in an ACGME accredited fellowship, and they are the ones that we are passing the baton to ensure that we are able to provide excellent care going forward into the future. But really, the team is much more than just the physicians themselves. Our growth has been substantial in the short period of time that I've been here. And it takes a lot more than just the physicians in an effort to provide outstanding care for our population. And that includes a large stroke center staff of coordinators, program coordinators, very dedicated, ancillary staff, case managers that help in patient process and flow, advanced practitioners who help to complement the efforts that the physicians are providing, both in the inpatient and the outpatient setting. And then again, I want to highlight that we have a dedicated research staff that's focused solely on advancing our stroke care and our knowledge so that we can continue to provide the best for our population in Phoenix. The stroke team concept goes way beyond even the individuals who are in the stroke program proper. And really, it's been said that stroke care is the ultimate in medical team sport. There are no bench warmers, there's no second stringers. It requires an enormous number of individuals who form an interdisciplinary stroke care team, with the focus being the patient in the center. Really, all of this team orbits around the patient proper, and it extends well beyond just physicians. It extends beyond vascular neurology. If you think about the number of healthcare providers that a stroke patient would see, this starts in the pre-hospital setting, in clinics, in prevention. You're going to hear a little bit more about that in just a minute. It also includes EMS and pre-hospital personnel. I'll tell you a little story about that. All these patients come through the emergency room, and so an entire dedicated staff, emergency room physicians and ancillary health providers who are familiar with a stroke and what the patient process is and how to expedite workup and triage and treatment plans. Then the acute inpatient setting, the subacute inpatient setting, you have physical therapists, speech therapists, occupational therapists, nursing, nutritionists, et cetera, other MD professionals in neurosurgery and endovascular neurosurgery, cardiology, pulmonology, critical care medicine. I mean, it really is truly a team sport, and we are focused on ensuring that all of the team is up to date and working in cohesion with each other so that we can provide excellent care to the patient. And we are orbiting around the patient, and that is our focus. Why do we hold that so importantly and dearly? Let me tell you a story about a patient who came in not too long ago. This is a gentleman, 53 years old, and not sure if my pointer is actually working. Is it? Okay. You really have to keep it moving. So I hope I don't give anybody, make anybody dizzy by moving this thing around. 54-year-old gentleman. No prior health history, no chronic health conditions. This is a regular guy, just like most of us. And he's up in the morning, 5:30 in the morning. He's getting ready for work. And so that's the last time he was known well. His wife is also up, but going about her morning routine as well. And then realizes a few minutes later that he is completely paralyzed on the right side. He has right hemiparesis and he has aphasia. These are profound deficits that would be devastating to anybody, let alone a 54-year-old gentleman. So he's completely paralyzed on the right side of his body, and he can't produce any speech and he can't understand any speech. Has an NIH stroke scale initially of 13, profoundly impacted with this stroke. So his wife, who is alert and recognizes the signs and symptoms of a stroke, calls 911, and the dispatch call goes out at 5:49, 19 minutes after he was last known to be well. EMS and the mobile stroke unit, our best Jew, is on the scene at 6 a.m., only a half hour after he was witnessed to be perfectly at his baseline. And then the patient's transported inside the mobile stroke unit. 6:09, he hits the mobile stroke unit where he undergoes an evaluation and diagnosis by the nursing staff that's in the field, as well as a vascular neurologist who is following the entirety of this interaction through a telemedicine portal. So we can see him on video, we can speak with him and the support staff that's in the field. And within 30 minutes, we have done a CT of his head, evaluated him as an appropriate candidate to receive TPA, which is the only FDA-approved medical therapy for acute stroke, in his driveway less than an hour after he was last known well. This is remarkable timing. This is the team concept. This is teamwork. Because he's being evaluated by a vascular neurologist who has insight as to different types of stroke, there's the recognition that this is probably involving a large vessel. So he has a large vessel occlusion, which is giving him these devastating deficits. And so he's transported emergently to our cath lab, where a team of endovascular neurosurgeons and support staff await his arrival, with the presumption being that he has a large vessel occlusion. And you can certainly see here, this is a diagnostic angio that was performed, and this entire area of his brain is being robbed of blood flow. So no nutrients, no oxygen. This is an area of the brain that will die and leave him with these deficits if nothing is done to restore blood flow into this area. So they go on and access that site. Right here is the area that is occluded. They're able to access that site by passing a very small catheter, a little tiny tube through his groin in his arterial system, all the way up to the point of the occlusion, and then mechanically disrupt and extract that thrombus. I've lost my pointer again. And you can see right here was the site of the occlusion. And then you see immediately the restoration of blood flow into this wide area of brain territory that is now being replenished with nutrients and oxygen, which was required to ensure that they didn't go on to die. Why is teamwork important for us? Over here are some national benchmarks. These are the goals that are required for a hospital to qualify as a primary stroke center if they meet these goals in 50% of their patient populations. So door to needle, this is the TPA administration. If half of their patients receive TPA in under 45 minutes, they meet the national benchmark. This gentleman had a door to needle time of 20 minutes. For national benchmark, the door to groin puncture time for cath lab admission and mechanical thrombectomy is less than 90 minutes in half of the patients. This gentleman had recanalization of that large vessel occlusion in 54 minutes. Why is the teamwork really important? The teamwork is really important because when he was discharged 2 days later, his NIH stroke scale was 0 as compared to 13 when he came in and was initially evaluated in the mobile stroke unit. 0. That means he had no impairments, no residual deficits at all when he left the hospital in 2 days. That's why the teamwork is important. I mean, we had to not give him a doctor's note just to prevent him from going back to work the day after we discharged him. This is exceptional care, and we strive to do it every day, and we want to move this from exceptional to normal. And with your help, we can do that. Again, I mentioned the 5 pillars that we base our efforts on, and clinical excellence really is the foundation. And you're going to hear from one of our experts about prevention, stroke prevention, in just a minute, Dr. McDonald. Research and innovation is key. And this is really an area that absolutely demands additional support. There's not enough support for research and innovation for us to get where we want to be. Now, one of our new initiatives headed by Dr. Paul McDonald is the Barrow Stroke Prevention Clinic. Prevention. We know what causes strokes. We know what risk factors for strokes are. We can help prevent strokes. In fact, we can prevent the majority of strokes that occur in our community with appropriate intervention and risk factor modification. There's a variety of them. We're here to help you. This stroke prevention clinic is not only staffed by vascular neurologists, but we also have additional professionals such as Dr. Kevin Yoon, who's a neuroendocrinologist, an expert at managing thyroid and diabetes, which are known to be associated with an elevated risk of stroke. We have Jessica Lubold, who's a nutritionist, who can help you plan a dietary game plan to maximize your health and minimize your risks for stroke. We can help align your lifestyle with Life Simple 7. These are things that have been demonstrated unequivocally to minimize and reduce your risk of a stroke. Let us help you. This is what this initiative is all about, because for sure, the stroke that you make the best recovery from is the one that you never have. Let us help you get there. That's where we want you to be. Research. I mentioned this is a crucial portion of our initiative here at Barrow. I mean, without the research, we don't advance care, we don't improve treatments, we don't make discovery. And this is really key and one of the fundamental initiatives that we're going to continue to perpetuate in the vascular neurology division. This also requires personnel. So not only do you see this talented group of physicians who lead clinical, translational, and basic science research, but we need support staff. These are clinical coordinators, research coordinators, compliance officers, IRB experts. We need the support staff in order to move the research forward. And we have it in place, and we want to continue to grow and be aggressive in research. We're also very privileged to have one of the foremost experts in the world in the interaction between the SARS-CoV-2, COVID-19 causing virus, and stroke. Dr. Wong has published over a dozen manuscripts in peer-reviewed journals just since the outbreak of COVID-19. I can't think of anybody else in the world who can make that claim. He's one of the foremost experts and recognized internationally, and we have him at Barrow. And you're going to have the privilege of hearing from him in just a few minutes too. So again, thanks for coming. Thanks for your support. We are indebted to you, and we need your help, and we appreciate your help in an effort of moving stroke care forward in Phoenix and indeed worldwide. It's a team sport. So first I'd like to introduce Dr. Paul McDonald. He's going to talk just a little bit about stroke prevention and introduce the concept of our new stroke prevention clinic. After all three of us speak, then you'll have an opportunity to ask any questions that you desire. Thank you again for attending.
Hello, everyone. I'm Dr. Paul McDonald. I'm one of the vascular neurologists here at Barrow, and I want to take a few minutes to talk to you about stroke prevention. Obviously, you know, as Dr. Waters pointed out, we've gotten very good at treating strokes when they occur, but it's time to consider what we can do to prevent them from happening in the first place. And so I came up with this concept of stroke prevention clinic, and it just kind of dawned on me one day as I had a series of realizations. The first one, as Dr. Waters mentioned, a large portion of strokes can be prevented, up to 90%. And that wasn't really a new thing. I'd known that already. But this is through what we call antithrombotic therapy, which are medications to prevent blood clots. But that's fairly straightforward. It can be something as simple as just taking a baby aspirin every day. And the relative risk reduction that comes with that is relatively minor compared to controlling a patient's risk factors for stroke, which can be much more challenging. And, you know, so I knew that already, but then I had the realization that, you know, our primary care providers, you know, like family doctors and internists who have traditionally, you know, been the ones to try to control these risk factors, may not be that good at doing so. And I don't know exactly why that is, but I think, there's probably a couple things. And one is that they may not be up to date with current stroke guidelines, but also they probably, can get preoccupied with the patient's other problems because they have to take care of everything. They don't have the luxury of just focusing on stroke prevention like we do. And then my next realization is here at Barrow, we have the resources to offer a comprehensive multidisciplinary approach to stroke prevention. Not only do we have multiple stroke neurologists, but we have a neuroendocrinologist who can help us with diabetes, which is one of the main risk factors for having a stroke. It's an endocrinologic condition. And we have a dietitian as well. And then the final thing I realized is that, I've been practicing neurology for over 20 years now in different states, different sides of the country, different environments, private practice, academics, inpatient, outpatient. And I never once could remember seeing a stroke prevention clinic anywhere. I can't swear to it that there's not one, but I just couldn't remember seeing one. And I'm like, why not? Why don't we have this? Why didn't I think of this before? But I thought I needed, somebody else to go along with this with me. So I managed to talk Dr. Wong into it. And then Lynn Ashby expressed interest, and I got Dr. Yoon on board. He's our neuroendocrinologist. And I was already working with a dietitian, Annie Hawkins, and Jessica took over her role. So we had this flyer printed up that we're trying to distribute to get the word out. So circling back to these risk factors, which I had alluded to as being the most important thing as far as stroke prevention, generally they're divided into those that are modifiable and those that are not. Those that are not are things like your age and your race, your family history, sex, socioeconomic status are generally considered non-modifiable, although you could argue that they might be modifiable. But the modifiable ones, fortunately, there's a lot more of them than the non-modifiable. And one of the main ones is, high blood pressure, diabetes is also important, high cholesterol, poor diet, physical inactivity, smoking, sleep apnea, and atrial fibrillation, which is an irregular heart rhythm that gets more and more common the older we get. And something called patent foramen ovale, or PFO. It's a hole in the heart that allows blood clots to bypass the lungs and go to the brain, causing a stroke instead of what we call a pulmonary embolism. So what are the services that we're going to provide? Well, we're going to be doing secondary stroke prevention, which is not a new thing. We've been doing that all along. But we also want to do primary prevention. So secondary prevention is to prevent a second stroke from happening. But the only thing better than that, in my opinion, is, keeping the first stroke from happening in the first place. So, and Dr. Wong and I discussed it. We want the clinic to be inclusive, not exclusive. So basically anybody that has, is at risk for having a stroke and they're concerned about it, they are free to come and see us for consultation. And, of course, we have expert, vascular neurologists available to consult with. As I've mentioned, we also have an endocrinologist and dietitian that patients can see if they need to. One of the newer services that we have to offer is heart monitoring to rule out this irregular heart rhythm, atrial fibrillation. And we've been doing external monitoring. That's basically a monitor gets sent to the patient, and they send it back when they're done. They wear it for about 30 days. And we have a cardiologist that reads those for us. But up until recently, we've had to refer our patients to cardiologists to have implantable heart monitors placed if they need one. And you can see a picture of it there down in the corner. It's a pretty small device, basically just kind of poke a hole in the skin of the chest and slide that under, and it can work for 3 years. So we're now able to do those for our patients. At least on the inpatient side, we're working on trying to get it on the clinic side as well, and hopefully that'll be forthcoming soon. And thanks to Dr. Teddy Yoon, we now have a transcranial Doppler lab. And what transcranial Doppler is an ultrasound of the blood vessels in your head. And as it turns out, this is actually a lot more sensitive for detecting a PFO or patent foramen valley than an ultrasound of the heart is, actually. What they do is they squirt some tiny bubbles in your vein and then monitor to see if they actually get up to the brain through this TCD. And hopefully at some point we'll also be able to offer ultrasound of the carotid arteries in the neck. So in the future, what I'd like to see happen is that we have a dedicated day for clinic at least once a month. Us launching this has been somewhat hampered, as you can imagine, by the pandemic. I think we launched this in May, and like the next week, in April, and like the next week, the pandemic hit. So haven't seen a lot of referrals yet, but we're still trying to get the word out. We have started to see referrals from internally from Barrow, but I'd like to see enough referrals that we could have clinic at least once a month, and this will be convenient for the patient. They'll be able to see multiple providers on the same day. And also it'll promote collaboration. You know, if us vascular neurologists are all in the same place at the same time, we're more likely to pull each other aside and say, hey, what do you think about this case or that case? And ultimately, it'd be great to have cardiologists there as well. So the brain heart clinic, that's not a new concept. I think they have one at Mayo Clinic, at least in Minnesota, if not here. But basically it's where neurologists and cardiologists collaborate to decide whether patients need certain devices to prevent stroke, mainly closing off certain structures in the heart. For instance, in atrial fibrillation, most of the clots come from the left atrial appendage, and you can place what's called a Watchman device in there to prevent that from happening. And there's a picture of the Watchman device there. But you can also do this for PFO or patent foramen valley. It can be closed. And all this can be done percutaneously with a catheter, so they don't need open heart surgery or anything like that. But, so one day I'd like to see this happen, and we're working towards that. And I'd like to thank you all for your attention and your support. And I will turn everything over to Dr. Wong at this point to talk about COVID and stroke.
Well, while we're doing the slides, I'll try to get ready. I'd like to really thank the foundation board and our stroke division to have this event. And because of all of you are supporting BNI, so we can have more opportunities to do more things to help our patients and treat the patient better. So your support is very much appreciated. I'm kind of a little bit new kid on the block. I've been here for about a year. I really feel privileged to be part of BNI, which is really a great neurological institution in the world. And so my part of the share of this part of speech is that what happened with this COVID-19 and the neurological problems. This stemmed from the opportunity that we work with the Union Hospital in the epicenter of Wuhan when the outbreak started. They asked me to help to analyzing data, and we also looked other data together. And later on with the American Academy of Neurology, to look at what is happening with this new disease in a sense, then its impact on the neurological system. As you know from this picture that most of you probably are being familiar with, that COVID-19 is an RNA type of virus that has these little protrusions or antibodies or antigens that will attack something called the ACE receptor, angiotensin converting enzyme receptors, in many parts of the tissues, mostly through the airborne, going through your respiratory tract, go to your lungs and attacking lung tissue. It's kind of hideous initially in the peripheral of the lungs until they really damage the lung tissue and then fill up your alveoli, and then you have trouble breathing, and then going from mild to moderate to the severe stage. Now that is truly a typical COVID-19 invasion, more likely going to that route. On the other hand, we realize that maybe there's more to that, to this virus, but this is a typical way how it invaded a person. We also learned that there may be the course of this disease that go through almost 3 or 4 stages. And most of people who are infected may be mild and with cough or fever will probably dissipate or go away within 3 or 5 days. But with your own body immune system to fight for that, and young people, healthy people more have a likelihood of success to get rid of that. But then people who are older with the pre-existing conditions such as hypertension, diabetes, obesity, and immuno being suppressed, such as those people who have had transplant, then they would have probably a little tougher time to fight this, and then may go into the next stage. And this is where that we realize that neurological problems become more prominent. However, the COVID-19 and neurological manifestations can also manifest in the early times. Now we have known. So these are kind of the timeline for that. And if you could do well before 5 days, and then more likely you'll be over with it. But many may go into the 7 to 14 day period. The percentage of that is about 4% of people who may go into the ICU of people who are infected. Now, if you take a look at this, which was from 4 days ago in Arizona, now we're actually approaching 215,000, and with 34 new deaths from yesterday. And also, that's approaching 5,500. You can see that this is our graph from our state. And as I mentioned, that there are about 10 to 20% of this tested positive people will probably be needed to hospitalized. And then 4% of those will have to go to ICU care. And 1% of that will get a stroke, or as we'll show you about that. But what we also know that, as I mentioned before, that COVID-19 is a new disease, unlike a common flu, and may cause neurological problems. And this data was, published in JAMA Neurology and others. I don't have to go into the details of the methodology, but I'd like to show you the results that COVID-19 would actually invade brain tissue, nerve, or muscle directly. And this has been proven by autopsy, actually, that it also can penetrate the blood-brain barrier, which is a wall between the brain and the rest of the body. Someone get into that, and then you get infection inside the brain. And maybe this can happen when the white blood cells wrap up the virus and penetrate the brain. So with that, we would have central nervous system manifestations of symptoms, and also peripheral nervous system problems, along with the muscle injury. So initially, that a patient come to the emergency room may present with taste, smell problems, or loss of taste, loss of smell, and severe nerve pain, along with muscle pain. And these patients, sometimes what we learn from Wuhan is that they do not have cough or fever. They would come in with these neurological complaints. And people initially thought that this maybe not something severe until they were all later on testing positive for COVID-19. So what we learned that we would educate our ER physicians that these should be carefully watched for when patients come to your emergency room, and they're actually being added to the CDC's guideline in terms of recognizing the COVID-19 symptoms. So it was later on that a stroke would happen, but more likely in the initial stage would be these symptoms along with headache and dizziness. And this has happened in terms of the comparison of common flu to COVID-19, that the chance of losing taste and smell is about 10 times. And this is a different study. So we have learned that peripheral nervous system, central nervous system, muscle are commonly being affected by this terrible virus. And smell, taste may be the first manifestation of COVID-19 infection and may not be long-lasting after the infection. But we also learned, which is bad, is the stroke part. You can see that in the early time of this year, New England Journal of Medicine published 5 young strokes coming from these soft clot forming. Well, everything else is negative or normal that causing these big strokes. So we have learned that in the later stage of COVID-19 infection, because of the cytokine storm, your coagulation system are messed up, your system are more likely to be clotting, and they form these thrombus, and they started causing large strokes. So this is the one thing we learned, that stroke may have a new cause in addition to the other causes and problems that Dr. Waters and Dr. McDonald mentioned. That in this stage of COVID-19 infection, we should be vigilant, especially young patients who have strokes, to look for COVID-19 as potentially caused, and these clots may be forming. And this has actually reported in New York study, about 1% or so will have big strokes, and these are COVID-19 peripheral infections of lung, and then in a later stage, they become consolidated, and then they have these big strokes. And also, in the Henry Ford Hospital, they have these bleeding type of stroke in the middle part of the brain and cause trouble. So it seemed to be kind of established that COVID-19 will cause clotting issues, causing strokes, in addition to other neurological symptoms I mentioned, encephalitis, nerve injuries, and muscle injuries. But we also learned that there are some laboratory signs that may hint to us that the clotting system could be in trouble. When is the lymphocyte may go down, when is the platelet count will go down, and stuff like that. So we now have to be watchful when these laboratory studies are become abnormal, when our COVID-19 patients are admitted to the ICU. So if you see that, along with something called D-dimer, it's a splitting product from the clotting system, and the C-reactive protein, inflammatory indices, to be elevated to abnormal stage, then you have to be watchful that thrombosis or clotting formation causing stroke or heart attack may be coming, or a clot to the legs are maybe coming. So those are the signs that we will be watchful for. Lastly, I want to share with you is that indeed, that the recent publication showed that the infection of COVID-19, sometimes some of the symptoms may be long-lasting, such as fatigue, trouble with the breathing, and trouble with the joint pain and stuff like that. However, the taste or a smell problem may dissipate when you recover. And also, the clotting problems may actually resolve if you recover from COVID-19. However, on the other hand, people with the brain infections causing encephalitis and the strokes, it may have a tough time to recover. So this is a terrible infection, and we need to do everything we can to first prevent. Second, hopefully we can find some way of treating that, and obviously vaccine will be helpful. Lastly, for us in the neurological field, we have to watch out for COVID-19 invasion of the neurological systems and watch out for it as a cause of stroke, especially in young people. So in summary, that we now know that probably COVID-19 is a new cause of stroke, which is about 1% of the time that will do that, especially in younger population. And this coagulation problem, it can be common in severe stage of the infection. And so what we learned is that, and in also changing a little bit our care protocol here, is to be vigilant about those people who present with neurological signs, even though they're initially or have not been tested for COVID-19, and they should be tested. Testing is important, not only identify a potential cause for a neurological problem, but also for us to do adequate quarantine and prevention. And then we also have implemented at times that people who are in ICU should have D-dimer lymphocytes and platelet to be checked on a frequent basis to look for potentially a turn, that a sign that maybe people are at risk for forming clots. And lastly, we could do some treatment in preventing clot formation by implementing blood thinners in the earlier times, but for probably short term. So that's kind of the information I'd like to share with you all, that what I'm trying to emphasize is that COVID-19 is a problem that is not only new and invade the respiratory system, but also it will invade other organ systems, especially neurological systems, and causing trouble. So prevention is important, and wearing masks, follow social isolation, and will be helpful until we are able to have a vaccine to help us to prevent it from happening. Thank you all.
We have a few questions. One of them is, you participated in some research about COVID and stroke. You found young people were having strokes during the course of the illness. Can you elaborate at all about what you know so far about that relationship?
What happened is that most strokes would be happening in older people because of the so-called atherosclerotic disease. And COVID-19, because of the infection that caused the clotting system to be all messed up, then they are likely to form clots. And this would happen in almost everyone who's infected. And so in younger people who are older, younger than age 60, even in 50s, and those in 30s, when they have these strokes, they're number one, bigger strokes. Number two, they have fresh clots. Number three, the other vascular system are normal. So we should be vigilant and test for that in early times to know that that maybe is the cause.
Dr. Wong, on your second to last slide, I believe you listed something, an immune system storm. Can you describe that?
So what happened is that when the virus invade our body, we want to form our own defense system. So your immune system start to be turned up. And this is something called the cytokine storm. So when your own response, your white cells, your lymphocytes, and are adequate to eat up the virus, then you're good. However, when they're having trouble fighting that, when viruses replicate so much, so fast, and then they try to generate more of these immunological response to fight the virus, and that will cause damage to your own tissue and system. And when that happened, they will cause disorders of not only immune system, but also because of the clotting systems tied to that, and then become troublesome. And when that happened, and then your other organ systems will all be involved, your kidneys, liver, the brain, and heart. And we have seen a few reports that people did the autopsy on COVID-19 who died. The brain blood cells, the brain blood vessels, on top of that, they have a lot of clots, even though they do not see that on the scans. So that is kind of step 1 to 3. Infection becomes severe, cytokine storm, immunological storm, and then coagulation abnormalities, clotting all over the place.
All right, another question is, when might you expect a better understanding of the long-term neurological consequences of COVID?
Good question. As you know, the entire world and our nation are still in the middle of this. And so we do not have a good notion as to how long these symptoms may manifest or last. So this is still a study being done, being followed. Hopefully we'll have more data for that in the future.
And then last question, what are your chances of having a stroke if you have a family history of strokes?
I would ask Dr. Waters what Dr. McDonald answered.
It certainly depends on what the etiology of the stroke is with respect to family history. And this is something that we would tease out in, for example, Dr. McDonald's stroke prevention clinic. It's a hard answer to give clearly because you may have a family history of strokes because of clotting disorders, hypercoagulable states, for example, autoimmune disease. Perhaps, or it may be more of the routine risk factors that we see every day, for example, diabetes and hypertension. We know that diabetes runs in families, And so if that's the reason that you have a family history of strokes, then addressing that is pretty straightforward, and that's strict management of the diabetes and the hypertension. If it's something more esoteric, if it's autoimmune disease or collagen fibro, dysplasia, something like that, then there may be other avenues to focus for secondary prevention.
Some of it depends on the age that the family member had the stroke. So if they're less than 50, that's a bit more concerning than if they're an older person. Unfortunately, it's not that unusual or uncommon for an older person to have a stroke, but it is for a younger person.
Well, I have another question, sorry. Dr. McDonald, on the stroke prevention clinic, what's incredible is what you're doing to help the community, all of you, both not only get there before anything happens, but get there as quickly as possible when something does happen. And I'm curious on the prevention clinic, as you're trying to build, are you looking for people to self-identify, or are you looking because of a family history or something, or are you looking for physician assistance? How can we as a community help you help people?
Yeah, really either way. If we have a patient who has risk factors for having a stroke, they're concerned about it, they don't need a referral from their primary care doctor, which, of course, depends on insurance, then they can just call us and schedule an appointment. Of course, if you're a primary care doctor, internist, family medicine doctor, what have you, and you're concerned about your patient's risk for having a stroke, then you can refer them. So either way, it can be a self-referral or, physician generated. Does that answer your question? Okay.
Well, I'm just going to say thank you to all of you. Appreciate your time and your willingness to help educate our wonderful donors and our supporters of your program with all the advancements you're making on a daily basis to help us keep us safe and healthy. Thank you very much.
Thank you. And thanks for joining us today.
Thank you.